Of course, we want to resuscitate these patients if we have to, and we'll cover the ifs and whens later on. And of course, we don't have blood products. Who has blood products? Well, the hospitals. So you have to, we have to be realistic and practical when we're treating trauma patients. We have to appreciate what we can do for the patient and what we can't do for the patient. We have to quickly make the decision, does the patient need immediate resuscitation or immediate transport with resuscitation on the way to the hospital? Because the fact of the matter is we don't have blood, and in most cases blood is what the patient needs. So here's your general assessment of circulation, which is heart rate, blood pressure, cap refill, skin assessment, and mental status. We frequently underappreciate a good, thorough physical exam. Taken in isolation, none of these matter a whole lot. They actually matter very little. But your capillary refill can give you a lot of information. And the capillary refill, what we've come to find out, although we're switching to a lot of different hemodynamic monitoring modalities that appear fancy, but when you look at cap refill, specifically in septic shock patients, it can help determine a patient's volume status almost as well as other things that we use. Skin assessment. If the patient's knees are cold or if they have cool lower extremities, that's an early sign of poor perfusion. Now, would I take capillary refill in isolation and say, if my patient has a prolonged capillary refill, then they're in shock and I need to resuscitate them with lots of volume? Of course not. That's never the case. But if I have poor capillary refill in a patient that's confused or tachycardic, that is particularly concerning. Now, there are other good early signs of shock that we can use. One is the shock index, which is the heart rate divided by the systolic blood pressure. The shock index is used for more than just trauma patients. It's used as a trigger for TXA and blood, right? It can predict whether or not the patient needs TXA or blood, but it's also used in sepsis alerts, and it also is a predictor of whether or not the patient is going to go into arrest pre or post intubation. So if I have a shock index greater than 0.8, in all of these situations, that indicates a worse prognosis. So if I have a shock index of 0.9 or 1, and I think I need to intubate this patient, I might want to rethink this, right? And think, oh man, this patient could decompensate significantly after I intubate them. You could also have a shock index of 0.9, and maybe the patient doesn't yet have a systolic less than 90 and doesn't meet the criteria per our protocol for the administration of TXA, but you might be thinking, maybe I want to, get it out, get it ready, and maybe it's systolic is 92 and say, okay, I don't think Dr. Hilty is going to be too mad about this, or maybe I'll call med control and get orders for it. So it is specifically useful to think about shock index. It's pretty simple to calculate. We've got calculators on our phones, heart rate divided by systolic blood pressure. That should be pretty easy to remember for everybody. Now, I preach end-tidal CO2 a lot, and it's very useful not just for, cardiac arrest or identifying respiratory depression, but it's also useful for when you use it as a marker of perfusion. What happens in cardiac arrest when we get a pulse back? Well, the end-tidal CO2 jumps up. Why does it jump up? Well, because the heart started beating on its own and there's more perfusion going to the lungs. It's also a good prognosticator. So if I have a patient in cardiac arrest and the end-tidal's 40, man, I really don't want to terminate this patient, even if they're in PEA, because they have good perfusion to their body with good CPR. Therefore, they probably have good perfusion to their brain. If we can just get a pulse back, then they could survive. In trauma, a end-tidal CO2 that is going down is a bad sign, because that usually means that they're losing blood or they have some form of obstructive shock like a cardiac tamponade or pneumothorax that we need to be concerned about. In this paper, they say that end-tidal CO2 cannot be used to rule out severe injury, but, however, it might be useful for ruling in, because they say end-tidal less than 30 may be associated with increased risk of traumatic severe injury. Permissive hypotension. Permissive hypotension, the much taught about, dreamed about, the new hotness in the treatment of trauma patients. So it's much more than a fad, and there is a lot to say about permissive hypotension. We should not be aggressively fluid resuscitating patients, and this article, in addition to many more articles that you can find online, allude to the same thing. So what does permissive hypotension mean? Well, it generally means keeping the systolic about 90 and not giving a lot of fluid to patients. Now, this does not apply to a patient with a traumatic brain injury or a spinal cord injury. Is the magic number 90 systolic? We don't really know. Some argue to keep it as only as high as you need to keep the patient mentating, right? If they're confused when their blood pressure starts dropping, then give fluid until they're mentating appropriately. I'm not exactly sure what the number should be. Just because the standard is 90, that's probably our standard, 90 systolic. Why does permissive hypotension work? Well, because if you give a lot of fluid that does not carry clotting factors like plasma does, if you give a lot of fluid that doesn't have the ability to carry oxygen to the cells, and if you give a lot of fluid that just causes the bleeding to be worse, contributes to hypothermia, all of the things that are bad in trauma, well, then it's just worse for the patient. I heard an anecdotal story that I thought was pretty useful. A very older senior paramedic told me that he brought in a trauma patient, had given liters upon liters of fluid, and that's what we used to do, right? Back when I became a paramedic, it was normalize the blood pressure. If you don't give 2 liters of fluid by the time you get to the hospital, then you're not a good paramedic. But he did that, brought a patient to UK, and the housekeeping or the cleaning person said, "Oh, they're not going to make it, are they?" He said, "Probably not. How do you know?" And she said, "Well, anytime the patient is bleeding out and the sheets are pink, then they don't survive." Meaning that once you dilate the blood so much that it comes out pink, then they're not going to live. And I thought that said a lot about that a person that's not really trained medically can predict when a patient does or does not survive based on what color the blood is. So good observation goes a long way. Now I'll give you an anecdotal experience of mine. I was transporting a patient that had an aortic dissection that was pretty significant, and it was leaking. All right. and I'm transporting this patient, not giving any fluid. Blood pressure was pretty good. During transport, the patient becomes diaphoretic, pale, and he said, "Oh, I don't feel any pain anymore." And he was in excruciating pain. And at that time, his blood pressure tanked to about 70 or 80 systolic. But he was maintaining well. Did I give him any fluid? No. Did I have 2 large bore IVs with fluid on pressure bags clamped off, ready to go? Absolutely. He was maintaining well. Blood pressure was 70, 80 systolic. I did not do anything. So that is permissive hypotension. And of course, it is not applicable to patients with increased intracranial pressure or spinal cord injury. Why? Because cerebral perfusion pressure equals MAP minus ICP. Once the intracranial pressure goes up, if your MAP goes down, the perfusion to the brain decreases based on this formula. And that's frequently why you see patients with a traumatic brain injury that are very hypertensive, because they're trying to overcome the increase in intracranial pressure. So what about vasopressors? This is very controversial, and it depends on who you ask. Locally, our trauma surgeons, they give vasopressors. They give vasopressors in surgery when patients are bleeding out. Anesthesiologists do this. It is not something that is so controversial that you're likely to get in trouble if you do it. The problem is a lot of modern trauma courses like PHTLS teach to not give vasopressors. But imagine you have a trauma patient that has been compensating for a while. They're becoming bradycardic. It is possible that their endogenous catecholamines are not very effective. And circulating, all right, vasopressors in trauma. Again, another very controversial topic. And we don't talk about it a lot because, honestly, there's very few recommendations on if and when we should use vasopressors in a trauma patient. But, locally, and I'm sure it's widespread as well, but our trauma surgeons give vasopressors for peri-arrest trauma patients. They have specifically told us this. They give them in anesthesia when they're having surgery and they become hypotensive from bleeding. People do give vasopressors in trauma, so it's not a never event. Now, giving large volumes of fluid is really bad. We know this. There's not a lot of data showing that vasopressors in trauma are particularly bad. Because what are we doing? Well, we're giving catecholamines, right? Patients in trauma, if they become hypotensive, they have their own endogenous release of catecholamines. Now, the catecholamines that are physiologic within the body are very low compared to how much we're going to be giving. So they're generally not recommended to be used routinely or even first line. Of course, we should try fluid first, but ultimately it's not a never event. We should use it sparingly. And we do have a vasopressor protocol for medical shock. It's not specifically for trauma. Although we have had providers give vasopressors for peri-arrest trauma patients, and Dr. Hilty thought that it was appropriate use. And anytime we do anything not specifically in protocol, Dr. Hilty will review it, determine if it was appropriate after the event, and we'll go from there. So where do you put the IV or IO, and why does this matter? Why does it matter? Why not just do a tibial IO? Well, if you've got a blunt multi-system trauma patient that is bleeding from their pelvis and the vascular system is disrupted, we depend on the continuity of the vascular system to get the fluid and the medications back to the heart and the core and the rest of the body. So it is preferred that you obtain access as proximal as possible. Hypothermia in trauma, it is bad. We know this is bad. We say it's bad. You learn this on day 1 of EMT class. We talk about it. We say, if I'm not sweating, then it's not warm enough for the patient, and so forth. But what do we do about it besides increasing ambient temperature? Not a whole lot, honestly. But how bad is it? So there's 21% mortality rate in just environmentally exposed patients when their temperature drops less than 89.6 Fahrenheit. Now, if a traumatically injured patient has that same temperature, there's a 100% mortality rate. That's how bad it is in trauma. So, okay, we know it's bad. Why is it bad? Well, it's bad because of the trauma triad of death, and it's a negative feedback loop. One thing that goes wrong in this loop makes the rest worse, and it all contributes to severe blood loss. Hypothermia decreases coagulation, right? The colder you are, the less your clotting factors work, or they work less well, if that's proper terminology. They don't work as well if you are cold. So what do we do about it? How do we keep them warm? Of course, blankets, a vapor barrier, something that prevents the release of heat. All right, this could be a tarp, it could be a space blanket, it could be a lot of things, but we need a vapor barrier, and then we need an active heat source. There's such a thing as a hypothermia wrap that's very common in like wilderness settings. If you have a prolonged carry out of a patient, but could also be useful for just day-to-day EMS operations. And basically this is a wrap that consists of multiple layers. Basically we put an active heat source on the patient in areas of the highest blood flow. Surprisingly enough though, there is a lot of blood flow to your hand. So if you can keep the hands warm, then you can really warm the core, unless it's in a trauma patient, maybe they're vasoconstricted. So anyway, you warm the patient, you need some active heat source, and then you have a blanket. All right, you need insulation, and then you have a windproof, waterproof layer, which is a vapor barrier. Think of like a sleeping bag. Think of it as a sleeping bag. So this is the proper way to keep a patient warm. Sometimes the best thing that we can do is simply prevent further heat loss, and this is the best way to do that. There are commercial products for this that you can buy from North American Rescue, and we'll probably purchase these as we get to the cooler months. They're kind of expensive, but not terribly so, probably for the amount that we're going to be using them. This is a full body heating system. Now, even better than providing heat packs to areas of high blood flow is to provide a full body heating system that covers the entire body, and this does so. It is easy to activate, and it warms up quickly, and it provides very effective heat. All right, last part of the H. In March, it's hypothermia and head injury. So let's cover head injury. Of course, the primary injury is the initial insult. It's directly due to trauma. We can't do a lot about this, but where we can really improve the patient's outcome is by treating and preventing secondary injury. Secondary injury is the sequela of the primary insult. So after the initial insult, you have edema, elevated intracranial pressure, then loss of cerebral autoregulation. You have hypoxemia that results from an insult to the respiratory centers of the brain. You have hypercapnia, seizures, which increase intracranial pressure, and fever, which contributes to worse outcomes in TBIs, cerebral vasospasms, and then of course you have an increase in sympathetic tone. And a lot of these are treatable. In the pre-hospital field, our management of a TBI patient is focused on treating these things. Now, concussion is generally considered more of a mild TBI, and we have had our athletic trainers come and talk to us about concussion symptoms. This is a pretty neat concussion grading system that is listed in PHTLS. I do think it is particularly useful, and we will be called to treat and transport patients with concussion symptoms. So it is important to know how it is graded based on severity, but essentially from grade 1 to grade 3, it goes from mild, moderate to severe, and the main difference depends on how long the loss of consciousness has lasted and how long the post-traumatic amnesia has lasted. 24 hours versus less than 24 hours versus less than 30 minutes. No loss of consciousness versus less than a minute versus more than a minute. And then concussion symptoms vary. You can have all of these symptoms. It can be difficult to differentiate between a concussion and a traumatic brain injury. It can be very difficult. Now, when we're talking about TBIs, they're typically graded based on the GCS. It is not the best grading scale, but it was actually why the GCS was originally created. We use it literally for everything right now, but this was the original intent of the GCS. Now, if I tell you the patient has a GCS of 6, what does that mean? It doesn't mean a whole lot unless you're looking at the patient, right? It could be a combination. It could be like all 2s. It could be 2, 2, 2. It could be 3, then 2, then 1. So it doesn't necessarily mean a whole lot. So when you're calling a report for the GCS, you should kind of say I3, V2, M1, something like that when you're calling in a report. If that combination even makes sense, I'm not sure. I didn't really look at it. But the severity of a TBI depends on where they are on the GCS scale. Now, you may see this in a patient with a severe TBI. Typically, if a patient is posturing, they will have severely increased intracranial pressure to the point where they are herniating. They could herniate through different foramens or holes in their brain, and it affects the motor and the all the centers in the brain. This is why you frequently get like unequal pupils or fixed and dilated pupils and so forth. But typically, if a patient is herniating, they will have an epidural or a subdural hematoma. Now, epidural hematoma is bleeding from the middle meningeal artery, which kind of runs along here. Now, the classic finding that would make you think that the patient has an epidural bleed is that they have a lucid interval. They get hit in the head. They have this period in which maybe they initially have loss of consciousness, but then they have a period where they have a lucid interval before they lose consciousness again. Now, this is only present in about 20% of cases, but when it is present, then that is a pretty significant finding. Subdural, on the other hand, can be patients with a subdural hematoma can have a severe TBI, but it is frequently associated with elderly patients who have cerebral atrophy, which means that they have increased susceptibility to having subdural bleeds. Patients with that are alcoholics are at increased risk as well due to cerebral atrophy because the bridging veins stretch as the brain atrophies. Elderly patients, this is specifically important, elderly patients that are on blood thinners can have subdural bleeds from relatively mild trauma. So if they hit their head, it is very important that they seek evaluation, that they are evaluated and get some imaging. But also, a lot of them have chronic subdural hematomas, and we know how well of a historian patients are. Sometimes they might hit their head, they say, they got a little bit of blood in your brain, may go away, may not. These patients can have acute on chronic acute expansion of the hematoma on top of a chronic subdural hematoma that then causes subtle symptoms. For the most part, when we're treating patients with TBI, we talk about and we learn about mostly Cushing's phenomenon, which occurs in the setting of herniation. And a lot of the interventions that we perform focus on preventing or decreasing morbidity and mortality for patients with herniation syndrome. Now, not every patient that has a severely increased intracranial pressure will present with herniation symptoms. And what is Cushing's syndrome or Cushing's phenomenon? You all should know this without me having to go over it. It's bradycardia, hypertension, wide impulse pressure. What is wide impulse pressure? It is basically the difference between the systolic and the diastolic. It gets wider. And of course, they have Cheyne-Stokes breathing or irregular respirations. How do we manage a patient with a traumatic brain injury? Well, this is just routine housekeeping management. Elevate the head of the bed. Why do we do that? It allows the venous blood to drain. If a patient lies flat, or we elevate the legs and increase blood or make it harder for the venous blood to drain from the brain, well, then it's like a car crash in the brain. The arterial blood comes up and the venous blood, the pressure in the venous system is increased, so it's harder for that arterial blood to actually circulate through the entire system. So elevate the head of the bed roughly 30 degrees, loosen cervical collars. Why? Because a tight cervical collar can increase intracranial pressure by decreasing venous return, by putting pressure on those veins. Aggressively treat seizures. That means we're going to have a low threshold if we think the patient is possibly seizing to administer Versed, because seizures significantly increase intracranial pressure. We're going to avoid stimulation. What does that mean? Does it mean we're not going to shake them? Well, of course, but it's also smaller things than that. If we don't have to suction, don't suction. Intubating increases intracranial pressure. The patient gagging, vomiting increases intracranial pressure. So we're going to aggressively treat all of the things that could stimulate them to increase the intracranial pressure. Also, if they're intubated, we kind of want to sedate them deeply. We're not targeting a RASS of 0 or 1 so that they can kind of be stimulated. No, we're aggressively treating them. Now, what are other non-housekeeping ways to manage them? Basically, the Brain Trauma Foundation has guidelines specifically for EMS providers. Two things that we can avoid that will significantly decrease their morbidity and mortality are hypotension and hypoxia. Think the rule of 90s. Avoid an SpO2 less than 90% at all costs and avoid hypotension. This is why we can provide permissive hypotension except for patients with a TBI or spinal cord injury. Now, they say hypotension as less than 90 systolic. Other references cite higher, like 120, 110, 120 systolic for a target of a systolic in patients with a TBI. Now, then we ask, should we intubate this patient? We know that if we've got a shocked multi-system trauma patient, we could kill them by intubating them if we don't properly resuscitate beforehand. Intubation for a patient with a severe TBI kind of follows similar logic. If they become hypoxic or hypotensive during the intubation, we could increase their morbidity and mortality. Now, the literature on this is mixed. If you're arguing for paramedics to intubate, you may pull some studies showing improved outcomes when EMS providers intubate patients with a TBI. But if you want to argue against it, you could also find studies that show that we should not be intubating because we don't do it well in patients with traumatic brain injuries, and that decreases their mortality. So if you're a good if you're good at intubating, then you can decrease mortality. But if you're bad and you don't properly resuscitate them beforehand, and you're very aggressive, then you could increase intracranial pressure, cause them to become hypoxic, and worsen their outcome. So if you do make the decision to intubate someone with a TBI, it should not be a novice provider performing the intubation. You want to do it quickly with as little manipulation as possible, and while avoiding hypotension and hypoxia. So here's a summary from the Brain Trauma Foundation. They say that these studies suggest the need for aggressive airway management in hypoventilated or hypoxic TBI patients, either by ETI or bag mask ventilation. However, if the patient has an SpO2 greater than 90% with supplemental oxygen, the use of RSI does not appear to be a benefit and may be detrimental. So what should the end-tidal CO2 be in patients with TBIs? In the past, we would hyperventilate. We would basically breathe at a rate of 30 times a minute, get that CO2 down to 30, 25, 20. But why? Why do we do that? And why is it that patients that are hyperventilated, defined as an end-tidal less than 20, have a higher mortality rate? Well, what happens when we blow off CO2? Our arteries constrict. That's why people get tingling and numbness in their extremities, right? You're breathing fast, you're blowing off that CO2. You can make yourself pass out, and you can cause these neurological symptoms. And it's a self-correcting issue, but if we're doing it, then it's not self-correcting unless we correct it ourselves. So if you hyperventilate a patient with a TBI, the cerebral arteries constrict, which do decrease the space in the brain, right? Which can be a good thing, but it also decreases blood flow to the brain. What if we hypoventilate and the CO2 climbs? Well, the cerebral arteries dilate, increasing the space in the brain. We know from the Monroe-Kelly doctrine that the brain is a fixed vault, and it can only occupy so much space. So once the space increases, it has to replace something else in the brain at the detriment of the patient to occupy that space. But there does appear to be a sweet spot. So what are your normal end-tidal values? Should be 35 to 45. We want to target the lower end of normal. Now that there might be a role for hyperventilating patients lower than that who have impending signs of herniation as a temporizing measure until you can get them to the OR. I don't want to go into too much detail, but just know you kind of want the end-tidal lower end of normal, so about 35 to 40. I did hear from a neurologist that he will hyperventilate patients with a severe TBI until the pupils react. Just an interesting pearl there. So what about fluid therapy in TBI, in traumatic brain injury? Well, there's no great literature on this. There's few data. There is some concern that raising blood pressure may increase secondary blood loss after certain types of trauma, which then worsens cerebral hemodynamics. So another argument against fluid and trauma is, what happens when we give the fluid? Does it stay in the vascular system? No, it leaks out. Only 1/3 of isotonic crystalloid fluid stays in the vascular system. This can contribute to brain swelling. So while we kind of don't want to allow them to be hypotensive, we also don't want to give them too much fluid. Now there might be newer fluids that can and do stay in the vascular system. There's also hypertonic solutions. Now we don't really have hypertonic fluid per se, which can actually pull the edematous fluid from the interstitial spaces and the brain. But we do carry sodium bicarb. Sodium bicarb is a hypertonic solution. It's very hypertonic. And there's some literature comparing it to like 3% hypertonic saline. And the outcomes have been good, given just regular adult, like 8.4%, I believe it is, sodium bicarbonate. So that's something that we might see in the future.